there was still this need from industry asking, our sponsor, NGOs, nonprofits, and patients and participants. There's no clinical research glossary that's really designed for understanding. The glossary meets a need, a tool to build trustworthiness of the industry.
The right tool to help us communicate the right way to patients. Welcome to the SCDM podcast series on partnership in clinical trials. Welcome, Sylvia. So maybe for the audience, do you mind introducing yourself and what you do?
Sure. Thank you so much for inviting me to join the SCDM podcast. My name is Sylvia Baedorf Kassis. I am a program director at a center based out of Boston, Massachusetts in the United States called the Multi-Regional Clinical Trials Center of Brigham and Women's Hospital and Harvard. It's a big mouthful, so we call ourselves the MRCT Center. And I have this distinct pleasure of working on health literacy related initiatives in the clinical research space specifically, and have been focused in that work on more patient centricity, patient engagement, and developing resources that really are for the patient and are developed by and with the patient.
Absolutely. And maybe for the audience, SCDM and MRCT are collaborating on a plain language glossary. And do you mind explaining what it is?
Of course. First of all, I never imagined that this plain language clinical research glossary would become something that has been embraced by the data community. So it was an idea that was born a few years ago. I had come into my role at the MRCT Center and was asked to work on health literacy and clinical research as a big picture initiative. And so we developed an entire toolkit based on health literacy and clinical research for industry stakeholders to really think about how to communicate clearly across the life cycle. And then when we finished that, and we have a website and people can continue to use it to this day, there was still this need, and the need was coming from both industry asking, our sponsor counterparts, NGOs, nonprofits, and patients and participants. They were saying there's no clinical research glossary that's really designed for understanding. There are plenty of medical dictionaries out there, so we know that, right? And there are plenty of even pretty good, easy to understand glossaries for medical conditions. You know, and especially in specific niche areas. But as much as we tried, we couldn't find one that was clinical research focused. So the MRCT Center decided to take it on and try it as a pilot. And so we did a pilot in 2020 and released 53 words in 2021. And it was at that point that there was much more buy-in. And so we've continued growing it. And that's how we eventually came to meet you. You know, we were adopted by CDISC as a global standard. And so it became more, I think, interesting to folks in data to think, wow, there's standards now around how to communicate clearly. And even if there isn't a regulatory mandate yet, it's likely going to come, or there's going to be strong encouragement and guidance, and we'll be well-positioned, and you will be well-positioned to start to meet that need.
No, absolutely. And to be honest, when I saw the glossary the first time, and I saw some of the terms included like an umbrella trial, what randomization means, very complex terms that are easily misunderstood by patients, it became obvious that it was extremely useful. And as we developed a lot of material for patients, it became just a no-brainer. It was the right tool to help us communicate the right way to patients. And not only to patients, some of our newcomers in the industry. They have to learn so much complex stuff, and having a plain language glossary, and you have images, examples, simple definition. It makes it so easy to understand what it is. And congratulations, it's a very nice tool, by the way. And if we can elaborate more on the glossary, how do you want to see it used, ideally?
Well, it's amazing. You already highlighted some of the key elements of it that really go beyond just a definition, right? So we have focused on having a plain language, easy to understand sentence definition, and that is developed and voted on via consensus with a work group that works together and decides together, can I accept this definition? So we make sure that it's regulatorily sound, it's plain language, it's easy to understand, but you know, if you get a lot of people in the room, they want to start mixing this word here, and should we do this and this, you know, and it's like, no, it doesn't have to be perfect. It has to be accurate, and it has to be easy to understand, but we are not going to aim for everyone getting their perfect definition. So can I accept this definition? So that's the crux of it, and that's what goes through the CDISC public review to really build trust and gain perspectives. But there are all these other things. And why it's so neat for training and for education and knowledge building, both for professionals, junior professionals, and for patients and participants who are learning about trials, is because we'll have a use in a sentence, like many glossaries do. There's it's sort of a more info section that goes into a little bit more detail about that term. And then what we added with the latest iteration that came out in March 2024 was this concept around where might a person see this term. So, you know, and it's said sort of in the second person. So if you see this term, you might see the term randomization in the consent form, talking about which arm you might be assigned to, and it happens by chance. You know, but we really have a sense of really trying to engage the person in the written form. And then you also mentioned that we have images, and so each term has a graphic design developed graphic, whether it's sometimes it's a little bit more like a flow kind of diagram, depending on what it is. Like the definition for phase is very stepwise illustrated. Sometimes it's more of an illustration showing a scene, and we really wanted to harness the idea that people coming to a glossary are used to just seeing words, and we try to provide a contextual image that helps them kind of take in the words, look at the image, take it in again, sort of use different modalities to process. Some people like images, some people don't. They don't have to use it, but it's there to be engaged with if they want to. And I would just note, I know, it's like I'm selling something, and all this for just free.
No, and to be honest, it became obvious reading the glossary, looking at it, that there's plenty of opportunity for the audience. We can use the glossary for having more understandable informed consents. We can use the glossary to develop more understandable patient-reported outcomes. We can use the glossary for CRF, ePro completion instructions. We're talking about returning data to the patients. Can we frame it in a way consistent with the glossary so they can understand what's coming back from us? So I think there's so much value in it. It would be almost criminal not to use it. And I think it's why SCDM, I decided to partner with you and really to advocate for the use of it. It's extremely valuable to the industry. And to that point, it was even for patient by patient. Do you mind sharing how much patients were engaged in developing the glossary?
Yeah, I mean, so we have our team, and I guess over years there's been several people that have come and gone, but our goal is always to have at least a third of the group be patient caregiver advocate. And our group size tends to be around 27 to 30 people total. And so we have a librarian as well. We have people from industry sponsors. We have, as I mentioned, nonprofits and CROs represented. And then also these patient voices that are there. And the way that we've always kind of set it up is that you'd have a development team that has, it's a little bit bigger, and we all work together to come up with that initial definition, and that has patient advocates on it. And then it moves to an exclusively patient advocate review team. And that is about 6 or 7 people that look at that terminology and those definitions and then vote on what ends up being the final that goes through CDISC public review. And then public review has been great because we ended up taking the CDISC process, which is a wonderful, rigorous process. It uses the wiki and the JIRA, and it's like wonderful. But it's not necessarily as patient and public friendly.
Yeah.
And so what we ended up doing was actually developing our own survey within REDCap, which is like a survey monkey or whatever, and allowing people to enter their feedback via that mechanism, and then we feed it into the CDISC system. So there's still all the transparency, there's still all the tracking, but in terms of users coming to give feedback, it's much more user-friendly for them.
Absolutely,
so we even thought about it like that, because even if we're talking about professionals, we have now clinical research professionals who are coming in and giving us feedback too, because they are the front lines of the ones that are seeing the participants in the studies. So it's really helped to increase engagement. And so I will just say we went through public review again for our next 20 words this past, I guess it was June, July. And we went from having a few people do the CDISC process many years, last year, to having over 50 people engaged in giving comments, and not just like little piddly little comments, but and also not major critiques, but really thoughtful.
Absolutely.
Have you considered this, or this isn't still so clear? And so we were able to take that and adjust the definitions, going back to our work group to discuss the comments that came in and how we were going to address them. So really having a nice 360 process for it.
No, not that good actually. Is there anything else you'd like the audience to know about the glossary?
I guess for me, trust came up a lot, when we were talking about, at the recent SCDM conference, trust came up in terms of how do we build trust?
Absolutely,
what is a trustworthy resource? And it came up in a number of different places, separate from the leadership forum, also with our keynote, the narratives, the stories we tell around research. And so I guess I would just say, the glossary meets a need. It has a story around how it's been created and why it came into being, and it can be continued to be carried forth as a story of a tool that is built with people to increase trust.
Absolutely.
And build trustworthiness of the industry. And so the fact that, the MRCT Center is a small nonprofit that is sort of remains independent from other stakeholder interests and really lives in a pre-competitive space, it really, I think, helps to support this idea that this could become a tool that many different industry partners can use. And we have on our website, at this point, we have an Excel version that can be downloaded. So again, for that user friendliness, for industry folks, for data folks, it is downloadable. It can be saved as a CSV. Then we are C-coded, so all the definitions, by being a CDISC standard, is cataloged and documented in the inside thesaurus and all this. So really, there's these nice linkages where we've had patient voices integrated in, but it's also robustly documented as a coded terminology that can be adopted.
Okay. And by the way, how many terms are there now?
So we continue to grow, and I'm going to say this number, and some people say that's a lot, good job, and some people say, oh, you're not even scratching the surface. So whatever, 187 words is where we're at now. And major words that come up a lot, like randomization and placebo and double-blind and single-blind and things like that are there. And we continue to evolve in terms of managing scope. What are the words that we should prioritize? Because this process, as good as it is to have an engaged process, it isn't the fastest. And so, we're looking ahead to think about which words to continue prioritizing. And so I would add as well that, engagement with the glossary is encouraged and built in. We have on every definition a point at the end that says, was this definition understandable? Yes, no. If yes, awesome, tell us why. If no, so sorry, please let us know how we can improve. We have a contact form on the website as well where people can not only suggest new terms or get involved with public review or get notified when public review happens, but they can also be able to give feedback
Absolutely.
on the existing terminology. So we're really trying to make sure we're responsive as well and maintain that engagement. So I think, and this is what I always talk to with my CDIS counterpart, she's like, well, you didn't just put a resource out there and walk away.
Yeah.
Now comes the maintenance,
Absolutely,
the updating, the looking back. And so even with this new version that we have, it's actually coming out that's September, version 2, September 2024, and it'll be annual from here on out. We had to look closely at what changed. Maybe we noticed a mistake, had to update it. And then what's been added, and was there anything that we needed to remove, which we didn't at this point, but there's the opportunity to continue evolving it. Language evolves, the industry evolves, and we need to be staying nimble and agile.
Yeah. As an advocate and supporter of the glossary, I would say if a patient only understands what enrolling in a double-blind, placebo, control arm, umbrella study, 7 or 8 terms, that's already a great achievement, because that will be very hard for them to grasp what it means. So it's not necessarily the number. When it is already significant, understanding 180 complex clinical research terms will make a big difference to patients. So I think that's already a significant achievement.
Well, I appreciate that. And it's amazing because you haven't even mentioned the fact that the glossary is linked to in the journal for the Society for Clinical Data Management, and all of the definitions that are your technical definitions are accompanied by a link to the MRCT Center Clinical Research Glossary. So you've really taken the step to start to think about how even a technical journal can start to integrate concepts of plain language to make sure, again, for all the reasons you stated, training, transparency, education, that we can really have a common commitment.
Okay. No, thank you, Sylvia. And before we conclude the podcast, is there anything you want the audience to know about you or MRCT that you have not shared yet?
I feel really lucky to work in this space. Some of us, I'm a clinical research professional. I've been in the clinical research field for 25 years, and it was a bit of a up and down roller coaster along the way. I didn't always know that I found my place, and I went through a number of different roles over the years. But finding a place like this to work in health literacy, in clinical research, with patients, with other passionate, committed professionals who really see the value in elevating the participant experience and elevating clinical trials for how important they really are globally. It's just like feels really lucky because I didn't imagine this would happen like this. And so I feel really fortunate to be able to be the voice for all the people and my organization that really put the effort behind this and their commitment to it.
Well, thanks, yeah. And by the way, really thank you deeply and sincerely for partnering with us. I know when you reach out to you, you said yes right away. And it's really a strong partnership. We have a lot of opportunities moving forward. So thank you so much. I'm sure we'll talk more about the glossary. And if you have not checked it out, go to the MRCT Center and check the glossary. It's very useful to the industry. Thank you, Sheila. And goodbye.
Great. Thank you so much. Thanks.
Thank you.